Assalamu alaikum. This is Abdullah Iraqi. I'm back to have a speech about the circulation. We continue our journey in the heart, and we are talking to about pulmonary circulation. So, pulmonary circulation is the movement of blood from heart to the lungs for oxygenation, and then back to the heart again. That's simply expressed. So the pulmonary blood vessels, we are talking about them to compare between the systemic blood vessels and the pulmonary blood vessels. So the wall of the pulmonary artery and its large branches are about 30% as thick as the wall at the wall of the aorta, and the small arterial vessel contains little smooth muscle in their walls, not much amount. And the walls of the pulmonary venous vessels also contain some smooth muscles. So the pulmonary capillaries are large, and there are multiple anastomoses, so that each alveolus site is a capillary basket. So the alveolus itself are surrounded by the capillary basket, as they say it. And when we look for the alveoli, which oxygen being transfused or transferred or diffused from air to the blood, and carbon dioxide on the other direction, we'll find there is estimated about 300 million alveoli in the adult human lung. So each lung has 300 million alveoli. That's total about 600 million alveoli in both lungs in the adult, with a total surface area approximately the size of a tennis court. So each lung has a huge surface area with the alveoli there. So the alveoli are thin-walled structure with a total surface area of about 100 square meter. This is roughly half the size of a tennis court. So 200 square meter equals the real tennis court. The alveoli are surrounded by pulmonary capillaries. In most areas, air and the blood are separated only by the alveolar epithelium and the capillary endothelium, so they are about 0.5 micrometer apart. And the best way to show that is by a picture, and you can see here that is the alveolar wall is very thin, and we know that the capillary wall is very thin, and air and the blood are separated by very thin area, which looks like 0.5 micrometer. And you can see carbon dioxide comes out from the capillary blood surrounding the alveoli by gradient from the capillary blood. The carbon dioxide is high in concentration here. It goes by diffusion to the alveolar airspace, and oxygen, which is in higher concentration here, will go to the alveoli and to the RBCs. So the alveoli also contain other specialized cells. So the alveoli not just working for oxygenation, but there is other jobs, and they have pulmonary alveolar macrophages or alveolar macrophages. They have lymphocytes, they have plasma cells, they have neuro endocrine cells, and mast cells. So the pulmonary alveolar macrophages are an important component of the pulmonary defense system, because when we are exposed and we breathe and we got germs in the air sometimes, so when it goes to the there we have a defense system in the lung to protect ourselves from a lot of germs and some harmful particles. So these cells comes the PAMs comes from bone marrow, and are actively phagocytic and ingest small particles that evade the mucociliary escalator and reach the alveoli. So whatever comes, they will eat it. They also help process inhaled antigen for immunologic attack. So if there is another immunologic attack, they secrete substances that attack granulocytes to the lungs, as well as substance that stimulates granulocytes and monocytes formation in the bone marrow. And the PAM function can also be determinal when they ingest large amounts of substances in cigarette smoke or other irritants. They may release lysosomal products. And the high compliance, low resistance pulmonary circulations operates at the pressure that is 8-fold lower than the systemic circulation. So if the blood pressure in the aorta is 120, the blood pressure in the pulmonary artery might be 20. And maintaining low pulmonary artery pressure therefore is dependent on the compliance of the pulmonary vasculature bed. So the vasculature bed has to have a low resistance, so you still can have a low pressure in the pulmonary artery without having pulmonary hypertension. And that way you can keep the pulmonary artery pressure remains normal, as far as there is a big compliance of the pulmonary vasculature bed. The pulmonary vasculature unique in that it accommodates a blood flow that is almost equal to that of all other organs in the body. So every organ in the body have its own circulation with the blood flow going through it. So the lungs, both lungs, almost have equal amount of blood in the circulation, the same time as every other organ, all of them total together. And the blood flow through the lungs is driven by the pressure difference between the mean pulmonary artery pressure and the downstream left atrial pressure. So as far there is a connection between the both ventricles when by the pulmonary circulation, where the blood flows from the pulmonary artery, it goes to the pulmonary arterioles, and then it reaches to the capillaries, in the alveoli, and then would recollect in the the venules, going back to the pulmonary veins, and it ends with the left atrium. So the difference in pressure, so if the pressure in the left atrium is high, this will hurt the pulmonary artery pressure on the other side, and something not good would happen. So mean pulmonary artery pressure increases proportionally to the resistance across the pulmonary circulation through which blood must travel, and the amount of pulmonary blood flow. So the cardiac output is the pulmonary blood flow coming out of it. That's the cardiac output. So both the pulmonary circulation and the bronchial circulation contribute to blood flow in the lungs. So the blood goes to the lung is not just only for purification to get oxygenation, but also for there is a different circulation, we will call it bronchial circulation, which is for supplying oxygenation and the nutrients to the lung tissues. So in the pulmonary circulation, almost all of the blood in the body passes via the pulmonary artery to the pulmonary capillary bed, where it is oxygenated and returned to the left atrium via the pulmonary veins. The pulmonary arteries strictly follow the branches of the bronchi down to the respiratory bronchioles. The pulmonary veins, however, are spaced between the bronchi and their return to the heart. So bronchial circulation, the separate and much smaller bronchial circulation includes the bronchial arteries that comes from the systemic circulation, from systemic arteries. They form capillaries which drain into the bronchial veins or anastomose with pulmonary capillaries or veins. The bronchial veins drain into the azygous veins. The bronchial circulation nourishes the trachea down to the terminal bronchioles and also supplies the pleura and the hilar lymph nodes. And now here we have to know that the lymphatic channels are more abundant in the lungs than in any other organ. So the lung has a lot of lymphatic channels, and the lymph nodes are arranged along the bronchial tree and extend down until the bronchi are almost around 5 millimeters in diameter. Lymph nodes sizes can range from 1 millimeter at the bronchial periphery to 10 millimeter along the trachea. The nodes are connected by lymph vessels and allow for unidirectional flow of lymph to the subclavian vein. And now we're going to speak about the history of the heart cath, the right heart cath. So the first right heart catheterization in a human being was being performed by Werner Forsman, and that was on himself in 1929. And the diagnostic cardiac catheterization was introduced by Andre Cornund and Dickinson Richard in the early 40s. But selective coronary angiography, which we'll speak later about it, was described by Mason Sons in the early 60s. And here is Werner Forssmann, the pioneer of the cardiac catheterizations in humans. And in 1929, at the age of 25, while he was doing his surgical training at a small hospital near Berlin, he introduced a urethral catheter into his own right atrium. He was wondering what to do, and he arranged it with his nurse, and he wanted to take a picture and to see what happens when he put the catheter into his heart. So he gave himself lidocaine and get access and pass the catheter into his right atrium under fluoroscopy, and then he called the X-ray tech, and he walked with his nurse to the X-ray department and took a picture of the catheter that made him the first pioneer for right heart cath. And his main purpose was to give medication straight into the right heart, and that's how he, especially in emergency, that was his number one purpose. And secondly, to study the heart for diagnosis. He get fired, by the way, from the hospital he worked in after he informed his professors that he did that, and he told them about what is his idea, what's his protocol, and he did the second one, and then he was fired. Unfortunately, he was fired. And he tried to find another job in other hospitals, but no one gave him the capability, so he started to do urology instead of cardiology. But later he got Nobel Prize later in his age, when after the spread of the procedure. He was also injected contrast into his heart using uroselectan. This is in 1931, 2 years later, in attempt to produce angiocardiogram. And with 1932, the pulmonary angiography using a catheter in the right atrium had been done in Lisbon, Paris, and Buenos Aires. All of this because of our pioneer. And this is the X-ray picture for the first right heart cath in human being. You can see the urethral catheter going all the way to the right atrium. So we to understand how we need or how we can do any procedure, we have to know the anatomy first of the procedure before starting doing it. So right heart catheterization is commonly performed by accessing 3 sites, either the common femoral vein, the brachial veins, or the internal jugular vein. Um, so in the leg, the femoral vein becomes the external iliac vein and then drains into the inferior vena cava, draining into the right atrium. And the cephalic vein in the arm drains into the subclavian vein, which then drains into the right atrium. In the neck, the internal jugular vein joins the subclavian vein and forms brachiocephalic vein, and the brachiocephalic veins from both sides drain into the superior vena cava, which drains into the right atrium. The antecubital vein axis has been associated with shorter procedure time and fewer chances of significant hematomas. And we can see here the pictures for the anatomy. You can see the femoral axis, and it goes to the femoral vein until we go to the inferior vena cava. And when we reach the inferior vena cava, you can reach the right atrium. And so if you come from here, you can reach the right atrium from the inferior vena cava. And if you go through the antecubital area with axis, we will reach all the way to subclavian vein, and then we'll go to the superior vena cava. Also, with the internal jugular vein, here is it's so close, and we just mentioned it. So why we do right heart cath? The first indication, which is very important, is cardiogenic shock. So if there is a patient with cardiogenic shock, we need to have access to know what's happening in the right heart, and this will reflect a lot of things and enhance or speed up the treatment options for the patients. Evaluation of a patient for dyspnea or to diagnose or exclude pulmonary hypertension. So when the patient have dyspnea and shortened breath and he can't walk or he can't talk, and a lot of things needs to be determined, and especially by accessing the pulmonary artery and see what's happening, and also to determine constrictive pericarditis, restrictive cardiomyopathy, heart failure with a preserved ejection fraction. Also, the indication determine response to vasodilator therapy in pulmonary hypertension. So it tells us what the best treatment for a patient with pulmonary hypertension when they try multiple drugs, which is the best option for the patient with the pressure response for each medications, and for how is the dose should be done. This should be for detailed information for the right heart cath procedure, not as we just give the main frame information. Also, when there is a cardiac tamponade, to know what is happening with the pressure, because with the cardiac tamponade, the heart cannot squeeze enough blood out, and the pressure drops dramatically. But with cardiac with cardiac tamponade, you, as far as with pericardiocentesis will being done, we also do right heart cath. Also to quantify or qualify the shunt, left to right shunt quantification, to know how big the shunt, how the blood flowing from left to right, and guiding fluid management. Also, if the patient with needs fluid management, when you have hemodynamically catheter in the right heart measurement will affect and will help to give the proper amount of medications or a proper amount of fluids to the patients, and especially after surgery or complicated myocardial infarction, heart failure, or shock. Also, it's used for adult congenital heart disease, evaluation of cardiac transplant, surveillance status post cardiac transplant, pre-implementation assessment of LVAD, and the post implementation optimization after LVAD. So when you give the patient has an LVAD, you have certain adjustment for the machine to rotate inside the patient's heart and pump the blood out of the left ventricle. So there is the response of the heart of the patient's heart to the LVAD might be dependent on the number of the rounds per minute that the machine produce. So it needs to be adjusted, and with the numbers coming, you can understand the cardiac output, how much it would be. So the best output comes with the best numbers. That's for the benefit of the patients. Also, in valve disease, when there are discrepancies between clinical presentation and non-invasive diagnostic testing. So what is the procedure? How we doing it? We doing it by complete clean procedure. We're using chloroprep to prepare the site and sterilize the area of access to keep the field sterile and sterile drape applied. So if we go get access through the femoral area, we have to clean the groin. If we're going access through the antebrachial antecubital area, we will go to the brachial area and we clean it. Also on the neck, while the patient facing away on the right side, and we clean it with chloroprep. And the access can be done either by anatomical verification, and this was old way where everyone uses anatomy to get access to anything in the body. Nowadays, with ultrasound machines became more friendly and easy to use. Ultrasound guiding access is easy to be done, and with local anesthesia, first to the site with the insertion of a suitable sheath. So after get the access with the wire, and the wire is there, so we put a suitable sheath. The sheath or introducer sheath is on the side to facilitate the delivery of the wedgie catheter or Swan-Ganz catheter to record the hemodynamics pressures. And on each chamber of the heart on each side, the pressure get measured, and we can collect blood samples to calculate the cardiac output and the peripheral vascular resistance, but we have to have certain numbers, including the hemoglobin and oxygen saturations in multiple sites. And we can see here in the pictures that the chloroprep. If you are not familiar, with this cleaning or cleansing or sterilizing solutions. It has isopropyl alcohol 70%, and it has 2% chlorhexidine. And these pictures of the femoral vein with ultrasound, and you can tell it's helping. Here you can see on this area the artery in top of the vein, so to get access it will not be a good idea, because if you go from the skin all the way you will go through the artery, and this is not a good practice, because you might have a arterial venous fistula and hematoma, and a lot of complications can happen. And here in a better just move away from this spot we reaches, there is a femoral artery here, and there is the femoral vein here, common femoral vein, so access with a needle from the skin down will not affect the femoral artery. And here a picture of the neck, and you can see this is the internal jugular vein, and this is the carotid artery. So we don't want to go to the brain doing right heart cath. So it's very good to see this is a guide wire. So the guide wire, that is the wire here, and with the needle you got the access, and it goes here in the vein. So you put a tube as a sheath, and then over the wire, and we switch till we have a better or bigger sheath if they need that. And these are different wedge casters. So this is just a regular wedge caster, and this is a Swan-Ganz caster with multiple outlet, and it has here thermodilutional port to have a different way for cardiac output other than oxygen sats. And here you can see Dr. Swan and Dr. Ganz. So this is Dr. Swan, and he was at Santa Monica beach in California. He was watching the sail, and he found that the boat drives much easier with the sail opened and by the wind. So he started to add the at the tip of the wedge caster a balloon. So Dr. Swan has invented the Swan-Ganz caster with Dr. Ganz when they have the sensor for thermodilutional measurement of the cardiac output. And here you can see there is hemodynamics of the right. So people get confused sometimes because they are not familiar with the pressure waves on the right heart, but it's very simple when you look at it. The wave shape itself and the pressure. If here it looks like it's 5 millimeter mercury, so this will be mostly right atrium when without even looking at the X-ray. And when you see this shape for the right ventricle with this pressure, that tells it's the right ventricular wave, and there's a Swan-Ganz in the right ventricle, and it's measuring the right ventricular waves. So please try to pay attention to the shape of the wave to know where the caster is, even without looking at the X-ray position. And here the pulmonary artery pressure, because the pulmonary artery pressure, it looks like the wave shape, it looks like the systemic circulation, arterial circulation pressure wave, but it's very low. Here it's around 20, 25 rather than 120 or 130 or something like that. And then we go back to the shape of the wedge pressure, but it will be less big than the right atrial size wave, and it's almost about the normal value around 10 or below 12, and that's how it's very important to know the shape of the waves to know where is the catheter um, position, and you can label it if you are monitoring during the right heart cath procedure. And this is a real right heart cath, and you can see after the wedge we go back and we reach to the pulmonary artery. And here that's a real picture. For you can see this is the right atrial pressure, but this is not a normal, because we know it's like about 4, 5, 6, not 9, 11. And here is the right ventricle. So the right ventricle, we know it's about 20, 25. And here is the pressure is 83 over 7. So that's the right ventricle, the right ventricle pressure, and which will be the same almost as the pulmonary artery pressure. But this is the shape of the pulmonary artery, and the previous one was the shape of the right ventricular casters. Here, it has a special waves, and there is like V wave from the mitral valve regurgitation effect on the patients. So this with the wedge pressure. And I hope I was not so long, and I hope to if you have any questions, you can email me, and have a good day. And thank you.